This program is brought to you by the Forbes-featured Freedom Hub Health Plan, the alternative to overpriced and restrictive insurance. The Freedom Hub Health Plan is exactly what you need. By Frequency Medicine Associates, supporting health professionals and laypersons with safe and effective advanced telemedicine-like technology that can scan and help rebalance the root causes of stress and illness. By the Planet Lockdown film, which can be seen on the Freedom Hub's Rumble channel along with many great speakers. And by The Pavilion, a 21st century community hub that brings together many of the disruptive innovations featured by the Freedom Hub, including direct pay healthcare, farm-to-table dining, TED-like Freedom Hub talks, and more. Visit your-mp.com/pavilion solution for details. Welcome, everyone, to Wednesday's Health, Biz, and Politics show. I'm Jim Graypeck, joined by my amazing co-host, Charles Froman, and we have a great show for you today with innovators in healthcare and breaking up this whole cartel. If you're new to the channel, and by the way, I'm dark today. It's not because we want to represent more equity in the show. That's not a bad idea, though. Yeah, I'm in a new location right now, and the lighting, this is the best I can do. So should be better tomorrow. If you're new to the show, I will do a screen share, but actually I'm a little behind on that. So I'm going to bring up our website, which is your-mp.com. So that stands for Your Marketplace for Health, Wealth, and Freedom, your-mp marketplace. So here we are, your marketplace for health, wealth, and freedom, your-mp.com. And if you come over to past the Your Health, Your Wealth, and Your Marketplace tabs, which we recommend you look at, some good stuff there, you'll come to Your Media Hub. And click on that. And here we have the information on the webinars, Zooms, podcasts, whatever you'd like to call them. After you buy us a coffee, thank you, we come down, it is volunteer. So we come down to Health, Biz, and Politics on Wednesday and Freedom Hub on Thursday. These are two different subscribe buttons. I've had people ask me, well, I subscribe, but I'm not getting the show. They might have subscribed to Thursday, not getting Wednesday. So we do recommend subscribe to both, and then you're done. So down below the intros and the topics, we also have our channels where we post these videos, usually by the weekend or at least by Monday at the latest. We're on BitChute, Brighteon, occasionally YouTube when it's not censor worthy, and we're on Rumble. So take a look. We have great speakers. We hope to have that index for you soon, so you can just go through and look for whoever you want. We have all the past shows. And with that, let me stop the share and turn it over to you, Charlie.
Thanks, Jim. And under that same website at the Your Health tab are a couple of vendors that we promote, since buying them pays us a bit of money in addition to the voluntary coffee buying that Jim showed. And the Wow Cash Appointments app is one promoted vendor, and it's at this website link that you see there. If you scroll down, you'll see how you can join, whether you're a provider of any type, including a monthly subscription DPC provider, an employer, or an individual. And there's different plans built into the app, including the sharing that we sell here at Freedom Hub. And it's a way just to get cash transactions going without coding or reimbursement chasing. So I'll stop sharing that and just introduce Jay Keese. So he is a longtime lobbyist. Apparently, he precedes me on Capitol Hill, where he worked for the late Senator Hines, who was the senator when I worked for a Pennsylvania congressman, George Gekas of the Capitol, Harrisburg, excuse me. I'm in Virginia now, so confused the two cities. And he was a up-and-comer, a possible future president, until he, died in a plane crash. And that was shocking for everyone across the country. Sort of like when that Kennedy had his plane crash outside Martha's Vineyards. Heinz was a rising star from the Heinz ketchup, company. And so at Capital Advocates is where Jay is the CEO. He runs the DPC coalition as part of that lobbying effort. This is interesting. He has started a master's program at Lynchburg College in Virginia. It's the first master's program for designing health benefits. Now that's interesting. I think it makes sense for those who are fans of the show, because we've had so many Rosetta advisors over the 5 years we've had this program every week, and they work hard to design benefits. It's helpful to be math oriented, I think, so you can look at claims. Some of us just want to sell sharing with ICRAs. It's easier and not have to deal with the claims and let the vendors who bundle prices deal with the price problem. He's worked at the AMA, the Chamber, and DPC is something we've had a lot of guests present on. Most recently, you saw in the promo, Dr. O'Rourke, my neighbor here in Virginia, Dr. Purcell, South Carolina, Dr. Gold in Massachusetts, and a lot going back years. And the talking points are pretty. Is there? They can resolve almost all of your sicknesses and accidents. They provide continuation of care for those with chronic illness. So you don't have to buy a new appointment every single time you go back. They have cheap access to drugs, tests, and labs. Some of them have these special online referrals to specialists for a quick consult. Great for a big family, great for chronic conditions. We'll get into whether the cost benefit makes sense for the healthy person. That's an ongoing argument that we need to address. Also, we'll probably in Q&A get to the extent to which they are incorporating more integrated care, the future of medicine, since allopathy has a lot of folks skeptical of pill pushers. And we'll get to what is the best major medical combo for it, sharing, self-funding, insurance. Outside of Freedom Hub, I sell a sharing combo with DPC that includes preventive or does not include preventive, depends how much you want to pay per month. So with that, here is the lobbyist. I combine sharing with DPC, and sometimes for out of pocket, I'll add a health matching account that doubles your money over 3 years. But I really can't push a health savings account, which is the best savings vehicle for retirement, because of some dumb government laws. That is something Jay specifically has been trying to solve for a few years. It would be a game changer if I could sell sharing, DPC, HSA, and even HMAL4. But Jay, so there's your intro.
Well, thanks, Charles. I really appreciate it. I'm going to try to share this screen again. Can everybody see that? Yeah. So really appreciate it. As Charles mentioned, I run the Direct Primary Care Coalition, which is a coalition that's made up of really the founders of the DPC movement, first started by Garrison Bliss of Q Alliance in Seattle, which was the first major scaled DPC practice. And I'll go through a little bit of the story there, but really the reason it got started was that state insurance regulations, and then eventually the developing Affordable Care Act, ObamaCare, prohibited these arrangements from happening under state insurance laws, characterizing these DPC practices, since they provided care under a monthly fee, as insurance. I do want to make one correction on the intro. The master's program at Lynchburg, which was run by Tom Scott, I was an adjunct professor there, was teaching the history of health policy, what was wrong in the past and what could be right in the future. I think that program is on hiatus, but I can get Tom Scott's info to anybody if they're interested in enrolling that. I know we didn't have a program last semester, but there may be another one coming up this fall. So, and anybody who's interested, please feel free to get in touch. My contact info is here. And beyond just the DPC practices that are a part of the coalition, we have other members. We have supporters in the American Academy of Family Physicians and some of the state chapters there, Boeing and Amazon and other people that are utilizing DPC as employers are members. So we encourage anybody to get involved, and there's a join button. You can go click there. and thus ends the promotional part of our program. So on to some of the facts. When I first started this with Garrison in 2009, as we were looking at the ACA regulations coming up, there were about 100 DPC practices around the country. And now of the practices that we've been able to count through this, this is on our website. If you Google the term DPC mapper, it pops right up. This is an interactive map. It tells you where all the practices are. To the degree that we know, there are 1,900 practices. Of that 1,900, this includes some of the big boys, like One Medical Group that purchased Iora, like Everside. That may well, these employer-based practices that are larger practices may well encompass, 500,000 or so lives that we think are in DPC. But, I think one of the big points is that some of the smaller practices have been really able to thrive. There's a doctor that I work closely with, Dr. Marguerite Duane, who practices in the DC area, and she has a panel of 40 patients or so, and does house calls, does not even have bricks and mortar. And then we have practices like the now One Medical Iora practice that has 700,000 lives in, I think, 30 states around the country. So small and large. Charles pointed it out, the characteristic here is that there's a monthly fee. And really, if you want to define what DPC is, it's a monthly fee for all primary care services, which differentiates somewhat from concierge, where you might pay an annual fee for special unlimited access to the doctor, but then fee for service transactions still kick in, whether you as the patient or the doctor is reimbursing through insurance for all the care that's delivered. So all of the fees for all the primary care, all the contact with your doctor using the cell phone, 24/7 access to care, digital telehealth access, is all included in a monthly fee. And we'll show you some data that we've collected through a study with Milliman. The median fee is about $70 per member per month, which is about the price of a cell phone bill. And employer claims data from that study and many others going back to 2008 are showing that employers can reduce overall costs of care by up to 20% and perhaps even more by putting a DPC up front and then combining the two with a health plan, either through the employer or a health share or any of the other sort of innovative benefit suites that are out there. We've been really successful at keeping this issue bipartisan. And I'll be candid, when I walk into an office, whether it's in one of the 33, 35 states that we've worked in to try to pass these laws, or it's Congress, the first question I get from the member of Congress or the staffer isn't, what are the regulatory barriers? It's, how do I get this? Like, I love this. I really want to do this. Where's there is a doctor, that I can go to, and we can just point them to the mapper and say, yeah, there is. Here it is. But we'll talk a little bit about what some of those constraints were. But first, the good news. I mean, when you bolt on DPC to an employer plan, and it's important to mention that we always like to stress this. Charles mentioned, 90% of the care that you ever may need to be delivered in your life, you can do through a primary care doctor. But this is primary care. This is not surgery. This is not, hospitalization. It needs to be working together with, some other form of coverage for things that are outside of primary care. Then when it does, what really happens is the DPC becomes the insurance against using your insurance. By utilizing primary care up front, using those 90% of things that Charles talked about that we can do in the primary care setting, we don't have to do them downstream. So what happens? Employers save, up to 20%. You look at some of the other models that are out there in advanced primary care, ACOs, accountable care organizations, patient-centered medical homes. When agencies like Medicare or hospital systems that are employing those get them, they're really lucky to get 3, 4, 5, 6% savings when they do that. We're showing employers across the board, and have been since the first study we did with Boeing in 2008, up to 20% reduction. And how do you do that? 40% fewer ER visits, 53% reduction in those claims from the ER, because if they do go to the ER, the doctor's going to be part of the process. 25.4% lower hospital admissions. 99% of all DPC practices use telehealth. I have a DPC doc in Alexandria, Virginia. I've been to see him in the 5-year relationship that we've had maybe 3 times. We do almost all of the interactions that we do, either using a HIPAA compliant app that I can use. My kids, when they've been away at college, they're all graduated now and out in the world and off of my health plan, thankfully. But when they were at school, instead of going to the student center, they'd call Dr. Matt. And they'd say, "Hey, I've got a headache," or "Hey, I've run out of my prescription." And usually in a text transaction, rather than going to the student center, potentially getting sick because there's other people in the room at the student health center, they're having that concierge level of service, but again at a lower price. And the doctor I used was, I think the price for our family of 5 at the time was $200 for a family of 5 for soup to nuts primary care for everybody. We also found, interestingly enough, that 57% of practices actually dispense medication on site. Now, there are some states like Texas where you can't do this, but we've actually jumped into this fold. And if you go to dpcrx.org, you can see a new initiative that we have launched to sort of streamline and create a regular process for this benefit. We now have a relationship with AS Medication Solutions and a full a group of the DPC coalition working on this in an outfit called Lineal Health. And we are now delivering medications through this process of DPCRX directly to docs that can be dispensed in office or sent to the patient via mail order or using a prescription card. Usually at cash pay prices that are, like $5-10 for the regular maintenance medications. We can also adjudicate claims for vaccines that might be covered outside of the doctor's office, so the docs don't have to get involved with it. But the idea that primary care includes the dispensing of medications is something that has really come up as a major advantage with direct primary care. So we mentioned Dr. Gold. Dr. Gold in Massachusetts, one of our steering committee members that you heard from. He's got problems doing this because there's all kinds of regulations in Massachusetts that get in the way of doctors dispensing. But when we work with some of our other providers in Pennsylvania and Tennessee and in other states that have these laws, it's 100% medication adherence. People walk away out of the visit with their prescription. No need to go to the drugstore to pick it up. No copay, no deductible, not using the insurance. Another way to save the health system tons and tons of money by keeping the PBMs out of the system by reducing that cost. And again, more. And I think these are old numbers. We're about to go into the field with another survey with Milliman this year. I'd be astounded if it wasn't up to 70% at this point. So we're just seeing this grow more and more. DPC doctors are able to do this because they have time. In a fee-for-service practice, dispensing meds, even though they're prepackaged and barcoded and safe and secure, just isn't something that a lot of doctors are going to be willing to do. We talked a little bit about the differences between concierge, and particularly for HSAs, I think it's really important to point some of these out. And by the way, no skin off of my concierge friends at MDVIP and other areas that provide this really good service if you can afford it. The fact is DPC is providing these services for people at a lower rate as a part of an employee's healthcare benefit that just isn't concierge. Concierge is again often sort of like there's a double dipping. Technically, under the confines of the IRS law, a concierge service is a fee for non-covered service, whereas our services are all services that potentially would be covered. So this non-covered service might be an executive physical or something that you're paying for $1,500 a year that gets you with it the special access, the telehealth to the doctor. So we differentiate from that by saying, basically everything the doctor is doing in DPC are in fact medical services, which in fact, runs us into some problems under the tax code. But in addition to being less expensive than the average concierge practice. And then a lot of people see, well, that's the difference between DPC and concierge is just cheaper. It's not. It's completely different model, whereas concierge is still, I consider, within the fee-for-service world. DPC is completely outside of it. The words DPC, surprisingly to a lot of people probably on this call, were first put into the Affordable Care Act. In fact, I think Garrison, Norm Wu, the CEO of Alliance, and I really pulled these out of our hat. We had to call it something, and medical homes was a term of art that was, all the rage among Democrats that were putting the ACA together. We called it direct primary care because I think a lot of practices, including Alliance, were going to that, and so it isn't scary to everybody. Here's what the provision in the ACA says. It says it recognizes that DPC is an advanced primary care model, like some of those other advanced primary care models that we mentioned, ACOs, et cetera, that is completely outside of insurance reimbursement. Well, why is that important? What we have here is the federal government, the Department of HHS, and the rulemaking acknowledging that DPC is not insurance, it's primary care services. And that this law was actually related to the law that the first law we passed in Washington State in 2007, the Direct Practice Act, that called it as such. So what it says for the ACA is that if you, an employer or an individual have a DPC practice that you have contracted with, that you can combine those with the qualified health plan, and those two entities working together can then meet the essential health benefits requirements of the ACA. And candidly, this is one of the reasons that this model took off with employers. In 2009, employers are struggling under the individual mandate, the employer mandate, needing to figure out a way to provide lower cost health benefits as the cost of these benefits are going through the roof. Here comes DPC. Employer looks at it and says, hey, even if I don't save money, I can fix my costs at $50, $60 PMPM, then wrap either a self-insured plan or a stock MEC plan onto that, and I have coverage that meets the ACA EHB requirements at a significant lower price. So we were quite happy with the rules we got out of the Obama administration that finally in 2011, made it clear that DPC is not insurance, it's a health plan. Now, the rub here, the Obama administration, nor this administration, has no authority to tell state insurance commissioners what is and is not health insurance in their own state. So we then spent the next 10 years flying around the country to various legislatures, and we have model legislation that's on our dpcare.org website that is the sort of the godfather of all of these bills, to pass laws, or in some cases in the purple, insurance commissioner guidance that has the force of law in these states. It says direct primary care practices are not the subject of insurance, not the business of insurance in the state. They are in fact laws that protect anybody in a DPC arrangement as long as they have these conditions that are in the contract from being regulated by any state insurance commissioner as the business of insurance. They're not the business of insurance. They are, in fact, medical services regulated not by the insurance commissioner, but regulated by the Board of Medicine. So we're looking at Alaska, potentially Pennsylvania, although I think that's on hold with a little bit of turmoil we have in that state, and others that we might be working. I think Wisconsin's working on a bill as well that we'll continue to work on. But these gray states that are out there, some of them, we just haven't ticked off yet because they're difficult. Some of them we haven't ticked off because there's no need. But the reality is, you can look through, you can drive your car all the way across the country and on I-70 and I-80 and not run into a state that doesn't have a law that defines DPC as the practice of medicine and not the business of insurance. And here's a little bit of that history. I won't go through a lot of this, but we got to about 2011, 2012 and become, really engaged with employers. And we found this one major hurdle that still exists, and that's the HSA restrictions. We worked really closely with the Trump administration, the IRS, during the transparency regulations to get a rule that sort of clarified what we already thought was law, but it did clarify it for us, that direct primary care services, if they are medical services, are tax preferred, triple tax preferred, 213D qualified health expenses. That regulation, however, did not really cover the main problem. The main problem here is that if you have an HSA, the law says, and this was passed by the MMA in 2003, that if you have an HSA, it has to be paired with a high deductible health plan. And you cannot have any kind of agreement or contract with an entity that provides services like primary care that might be covered by a high deductible health plan. In other words, kind of like no double dipping. Or two, that you can't have another health plan that's not a high deductible health plan. Well, it's very clear that DPC is not a high deductible health plan. So if it's not a high deductible health plan, it can't be paired with an HSA. The remedy for this is the IRS says if an individual has an HSA and has a high deductible health plan, they don't have to get rid of their HSA. They just can't put any money in it. So we've got the Trump administration saying, hey, we have a situation where DPC expenses are 213 qualified, 213D qualified health expenses. But if you take money out of your HSA to pay for them, you're ineligible to fund your HSA. So I guess potentially you could fund it for 1 year, run it out, and then get back. But as you can see, these regulations are a mess. They haven't been updated since 2003. They need to be fixed. So what we have is S628, which was just reintroduced by Senator Bill Cassidy, the Primary Care Enhancement Act. What this bill does, very simply, it says that a DPC, arrangement that is differentiated from concierge, both by being a fee for covered service arrangement and a lower cost arrangement. So a DPC arrangement that is less in the aggregate than $150 PMPM, which is about close to double the national average, that will not be treated as a second health plan. That will make an individual ineligible to contribute to their HSA. It would allow these pre-tax funds to be used for DPC if they come out of the HSA. Now, to be clear, if you have an HRA or an FSA, you can use your pre-tax accounts to pay for DPC, but you can't with the HSA because that's where this Section 221C prohibition on that defines eligibility for HSAs lies. And it very clearly says that DPC is not health insurance the way these 33 other state laws do for the purposes of the tax code. The IRS is the only regulator left in the entire country, likely the entire world, that looks at this model of practice and says, hey, this is health insurance. So this legislation, if passed, would clarify that once and for all. Now, I will say that we were in the original CARES Act as one of the pandemic, waivers that the IRS would be able to give to people. That was stripped back in the CARES Act, and it was only allowed for telehealth. Now, if you have a DPC arrangement that only provides telehealth services, that is actually, you're completely fine to have an HSA with that right now. So one of the other areas that we're working on with Congress is, could we extend these telehealth provisions, which now have been extended to the end of the 2024 plan year, could we extend these and include in-person visits that would essentially be, bringing the Primary Care Enhancement Act into the law by simply, extending an existing statute that, of course, Congress never likes to sunset anything, but extending an existing statute. So, that's kind of where we are. I have some documentation in here we can show you. I know there've been a lot of questions about what are so-called the caps or the $150 limitations on the fees. Previous versions of the bill did say that it was limited, that it would not allow prescription drugs to be part of these plans. That limitation has been taken away. We think this is a really good bill. This is the Joint Committee on Taxes estimation of the cost of this bill. This goes back to 2019. I would imagine this has gone up a little bit, but perhaps not too much. But it's basically the Joint Committee on Tax is saying that if we pass this bill, it would take $1.7 billion over 10 years out of the Treasury due to lost tax revenue that might come in because these triple tax deferred benefits are now being used on direct primary care rather than going into the tax system. We think that number is high, but JCT and the Congressional Budget Office, this is the number they get to decide. This is a relatively low number, 1.764 billion, compared to some of the other HSA reforms that are out there that might be, 80 billion over 10 years if we were going to decouple the eligibility rules that would also fix us. But we do have great bipartisan support. In addition to Senator Cassidy introducing the Senate version of this bill, we've got Earl Blumenauer, who's perhaps one of the most liberal members of Congress, who is also oddly, a little bit of a laissez-faire. I don't know whether I'd call him a capitalist, but he certainly doesn't believe that the government ought to be telling people what they should and should be able to do with their tax dollars. So Earl Blumenauer is going to introduce with somebody on Jason Smith's Ways and Means Committee, the House version of this bill any day now. We're expecting to see that. Smith was he was the chair of the Ways and Means Committee, was an original co-sponsor of this bill before. The chairman is likely to give somebody else on that committee the ability to be the lead co-sponsor. But we're really bullish about passing this. We think we'll be able to chip away and get rid of the HSA restriction and really be able to give direct primary care to anybody, regardless of whether you have an HDHP paired with an HSA. And I will end my remarks there. I'm really happy to take any questions from the audience. And I see Charles Ford has a hand up, and but Charles Froman, I'll kick it back to you to moderate any Q&A.
Thanks, Jay. And Jim, do you want to moderate the questions, Jim? Or do you want me to? I see you're muted, Jim. So I guess I'll start until you. He just finished a big move. So
until I unmute. Okay, now I'm back, and I'll even give you a picture that doesn't really work. Oh, actually, it looks a little better, maybe. Sure. Let's start with a great presentation. Thank you, Jay. And I'd like to keep in touch because maybe there's some things here that apply to what we're doing with the pavilion and take this around the country. So
happy to do it.
Yeah, thank you. Charles Ford, you're up.
Thank you. Again, I'm a little rusty on some of the alphabet soup that was spewed out. So if I step on the wrong alphabet the wrong way, please forgive. But my first brief comment is, I don't know why you even worry about the HSA. It was designed for large deductible health plans. To try to now change its whole structure and function, forget it. Just walk away from it. You don't need it. That's just an observation. Spend your energy doing what you do so well, which is lowering the cost. My second question is, okay, I'm a risk manager of a company, and I'm using Charles Froman's idea with maybe a few other alterations to it in terms of providing benefits to the employees, so that the principal amount of the medical cost is being borne by medical sharing arrangements, on behalf of the employees. Well, your program improves outcomes, lowers variability, and drops down cost. But you're coming to me at the risk manager level and saying, okay, we're going to charge you $70 additional a month. And I'm going to look at you and go, okay, I'm paying $70 more a month at the employer level for this added value and benefit. And it's a benefit to the employees, but I'm getting nothing back in return other than I'm just getting better outcomes for my employees, maybe less time off from work. That said, it would seem to me, who is paying the claims? Who is the risk pool paying the claims? And it's obviously the medical sharing arrangements. So my challenge, my question, my concern, my idea is, why aren't you sitting at their table saying, why don't you integrate what we do into your process so that we can do this for all your members and you get the reduced cost of the medical health sharing?
So a couple things. First, let me address the first issue. The only reason we care about HSAs, I totally agree, is that 2/3 of employers offer them as a part of their health plan. So I'll give you a very real example. Boeing offers this to their employees that have PPOs and HMOs, but they're not allowed to offer this to their employees that have that have the HSA high deductible plan, and that's most of their employees. So that's why we need to fix this once and for all, and really just reclassify what this is as a health expense. On the other, I mean, Yeah, look, there's lots of integrated models. There's lots of standalone models. The fact is that $70 PMPM for employer plans is probably closer to 45 or 50 on average. That data is very closely held by employers and plans that have these arrangements together. But my guess is it's 50, $55 PMPM for like a plan that an Everside or a might do. I don't know. We don't because of antitrust concerns, we don't look at everybody's data and aggregate it. But the reality is, I think employers look at this as a great benefit for two reasons. Number one, the employees love it. In a world in which you're trying to compete for employee lives, you're able to offer them doctor on the phone services in addition to their PPO, and it actually does lower their actual cost of benefit on the back end. So, like we have never heard an employer say, we don't see the value equation. We do hear some employers saying, we just can't afford this additional outlay of money, but none of the docs that I've practiced with really have, sort of like shown that as a complaint. Now, it is precisely these regulations around HSAs, state regulations and others that get the brokers and the people who are putting the benefits together at the corporate HR departments all wrapped up. So we do have some solutions around that. For instance, right now we have practices that are more than likely offering that sort of telehealth benefit as an additional benefit. And then if they charge a low per visit fee for when they come in, you can get around that restriction. So people are doing innovative things around it. I would encourage anybody to go see a tax lawyer before they do those things. But the reality is we're creating the workarounds, and I think employers really like what they're seeing in terms of keeping people at work and mental and behavioral improvements to their employees, and just candidly, it's a benefit people love. So there's all kinds of intangibles in addition to the tangible benefit of reducing the downstream cost.
Okay, let me just briefly, and then I'll shut up because other people have got great questions. But my response to your response is, let's go look at Boeing just briefly, just for a second. All right, they got a PPO, it's self-insured. So who's paying the claims? They are. So your program working in their self-insured structure is going to lower the cost, improve the value, improve the benefits. Well, they're still wasting hundreds of millions of dollars a year with that plan structure. And Charlie and Jim can detail you on that. So again, if they were presented and they had the intelligence, and we are dealing with Boeing aircraft, and I'll stop right there. But if they had any intelligence and actually looked at it objectively, looking at what Charles with the ZICRA approach would use and what the cost would be to the employer, they would reduce their cost almost $4,000 an employee per year. Then, or where they're shifting the risk to, which is the medical sharing arrangement, they would bring you to the table as part of the services they offer to drive down their costs because they're the ones paying the claims. So that's you can't fix stupid. Boeing aircraft, they're stupid. Okay, they are unbelievably stupid, and they are corrupt. And that's typical of what you find in the C-suite. I used to do this stuff for a living. You got dumb, stupid people that want to continue to do the same thing and expect a different outcome. And you're running into that. And that you see it with the HSA. So I'm going to stop right there before I get on a rant, because there's other people that got really good things they want to talk about.
Jim, you're muted.
You're going to stop before.
You're still muted, Jim.
Thanks for taking my question.
Happy to do it.
As Jim figures,
I'm using the unmute, the space bar, but I guess it's not working. Okay. Any response to that, Jay, or should we go to Charles? Any follow-up?
I hear where you're coming from, and my only response would be, Boeing was probably the first employer in the country to do this, so they did something smart. They're not dues-paying members of my coalition, so I have no skin in that game. But you're absolutely right. There's a lot of groupthink that gets involved in what employers will and will not do, and that cautiousness shows up. And we're very agnostic about whether DPC is offered as a part of a self-insured bundle or a MEC or a this or that. I mean, we want the movement to grow so everybody gets great primary care.
Okay. Thanks, Charles.
Thanks. Just a quick defense of the HSA. I think a lot of agents like myself are selling it not so much as a source of funding for out of pocket, although it is useful for that, but really for retirement out of pocket. When you see all these studies where folks face 100 grand in liability for long-term care mostly, or even more than that, and our savings rate is so pathetic. Indeed, if you are chronic and have a lot of out of pocket, expecting a big expense or you need some elective therapy, you've probably heard of this. We have another account that doubles your money over 3 years, the health matching account. That's better for those who do expect out of pocket liability. So they could just keep funding the HSA as a tax shelter to build 100 grand for retirement when you need the money, whether for long-term care or you can use it to buy a boat if you're healthy. So it's a nice little end of life surprise. You can comment on that if you want, but how you combine things with the DPC, HMA, HSA. I had two questions. I think someone else is going to ask my other questions. I'll ask this one. Why has the government's managed care experiments failed so utterly, like the Accountable Care Organization compared to DPC? Do you have any thoughts on that?
Yeah, because they're still in fee for service. I mean,
Okay.
we worked really closely with HHS, CMS on the rollout in the Trump administration of what was then called the direct contracting model, which is now called the ACO REACH model. And, I would say, if there were a football game, they were at first and goal. They were really close to getting it right. And then they threw on top of this whole, convoluted bonus payment structure scheme that was, trying to match what they would get paid in fee for service and give them a bonus payment based on performance. They did reduce quality measures down to where we said there were 5 or 6 clinical measures that everybody could agree on that we were going to do anyway, and then they said, well, to make sure that you're seeing patients, we're going to put a $50 per visit fee on everybody. And it's just like, it was ridiculous. So they can't help but regulate. And so they regulate them down to lowest common denominator into a program that they feel like, either administrators at CMS or candidly administrators and benefits administrators do this all the time too. I'm hearing, are going to have to put something on it to, okay, well, we need to make sure. And whereas what our position is, if you let the gloves off and you take a bet on primary care and you're going to bet a low dollar amount, 50, 60, 70 bucks PM out of what might be, $1,000 a month insurance plan, let it do what it does best. And if it doesn't work, stop doing it, let it shine. So we take this very free market approach and very free market attitude towards it. Primary care doctors are really good at delivering primary care. Nobody's ever doubted that. You look at any, like quality survey or combined net promoter score of any of these practices, they're through the roof compared to, the best score that anybody else gets, because people love their primary care doctors and they love what they're able to accomplish in primary care. Imagine if you could put it on steroids and do more. I mean, I think it's just, Charles, it's just get out of the way and let us prove that we can do what we can do. And we even offered this as a model with CMS. Give us 4 years and make our goal to reduce your CMS, expenditure in healthcare by X dollars, 20%. Throw that number at us. And if at the end of that 4 years, we haven't reduced your cost by that much, CMS doesn't have to continue the program. That would be a great way to test it. That's what employers do. We're going to take a gamble on you for a year. We're going to try it. If you cost me money and my employees don't like you, you're out.
Okay, thank you. Michael, good to see you.
Hey, how's it going, guys? I got 3 questions for you, Jay. First question is, so I'm Propulsion Director with Americans for Prosperity. We are massive advocates for HSAs and absolutely on the DPC bandwagon. What I know, there's a really big push for DPC integration with HSAs a couple of years ago. What are some things about this fight this year you might recommend for outside organizations that want to advocate and see success to to maybe message or do something different than last time?
Yeah, that's a great question. I really appreciate it, and I'll be really honest. Again, Charles mentioned that I came to DC to work for Senator John Hines, who was a Republican senator, and spent my career working for, let's just be honest, those are Republican-leaning organizations. I'll be candid. Since January 6th, who knows, like who's what, right? So you get into the realm of politics these days, and you never know who you're talking to. I always have believed in this sort of free market approach to healthcare, right? And we have many Democrat members of Congress on both sides of the aisle. I mentioned Earl Blumenauer, Terry Sewell from Alabama, a great member of the Black Caucus down there, who sees this as a way to lift people out of poverty. Like we have widespread bipartisan agreement on this. We just want to change healthcare and make it better for people. The organized groups that have been, sort of like, so first of all, HSA is a 4-letter word to Democrats. If you go into the Ways and Means Committee and talk to Democrats, they're going to talk about HSAs as being the seed of the devil, and the way that Republicans want to give away health care to the bankers and financiers so that only the rich people can have it. Now, the fact is that I view HSAs as a tool that can help people save for healthcare, and put a little skin in the game in terms of consumerism, and they're a really good tool. I don't think HSAs are the savior of the healthcare system. I think they're a really important tool. If they went away and we still had direct primary care, my biggest problem would go away. So for me, if HSAs went away tomorrow, I would be out of a job because I don't have anything, like regulatory to push anymore. We've done everything else. So, I want to get away from that rhetoric where HSAs are somewhere between the savior of the healthcare system and the seed of the devil, and come in the middle and say, hey, these are really good tools for people to save for their healthcare and for long-term care in their retirement. So that's where we come at it. We're not advocates, candidly, for HSAs, for health shares, for health insurance, or telehealth, or anything else. We're advocates for every man, woman, and child having, no restrictions, no holds barred access to the best primary care they can get for under $100. So.
Thank you. Second question is, what's kind of like your take on I think it was like some efforts of like trying to incorporate potential some amount of like Medicaid patients with like a DPC like arrangement. I'm gonna try it out like in Washington.
Yes.
With like failures. I think there could have been some success in like Maine a little bit. I just kind of want, and I know there's like
Medicaid is really hard. There's a lot of churn. I don't need to tell anybody in the Medicaid program. You have individuals coming in and out. We've worked with a member of Congress in Texas who's really interested in putting a demonstration in where, these individuals who in Texas, of course, don't have the Medicaid expansion, coming in and out of Medicaid, particularly perhaps seasonal workers, migrant workers, farm workers that might have coverage part of the year, but might not the other part of the year. And they have Medicaid the other part of the year. If you go in and out, and Medicaid is providing DPC up front like they were in Washington, the lives go away. The other piece that's really critical, we've had better luck with state employees, for instance. We work with the New Jersey state employees unions to provide a DPC fronted plan to, up to 800,000 New Jersey unionized state employees, and they love it. The unions really pushed hard for it. So in that confine, there were agreements that were put in place that understood this is the data we're going to share. These are the outcomes that we're going to share. We're going to really understand how much savings is the state really realizing. And in the Washington State agreement, it was an agreement between a primary care practice and a Medicaid managed care plan. And those agreements with the state weren't locked down. And really what happened there was that the plan, the DPC plan that was in place, candidly, they were getting massive reductions in the cost of care. They saved so much money in the first year they did the program for the managed care company that the managed care company made more money than they were allowed under the contract. And there was a clawback of something like $4 million of funds at the end of the year. So the managed care company was the one that cut it, not the state, because they didn't want to write another $4 million check because, burden the hand, right? Nobody wants to make a cash payment, and they had to, and they said, well, we're not doing this anymore. So, look, it really is, if everybody looked at this with the right set of data, like we've shown people from Milliman, you'd understand where the savings are, who's getting better care, what the outcomes are. And, let's take the gloves off the data and have, insurers don't like to share that. Insurers don't like to say, hey, our HSA plan, that is paired with a DPC plan is a whole lot better than this more expensive plan over here that's PPO, where we're making tons of money on the fee-for-service transactions. So, we need to get to a completely transparent data environment where everybody is showing everybody else their drawers and understanding where all the savings are and where all the potential costs are. And DPC wins in that environment every time.
Hey, Michael, I'm going to have to cut you off right now. Maybe after, because we're running out of time, okay? On that third question, or maybe you can post it in the chat. I do want to make one quick comment. I don't know if it's related, but I remember back in Allentown Hospital in Pennsylvania a bunch of years ago, they put in a program for yoga and breathing in the cardiac ward, whatever it was like a test. And after a couple of months, 6 months, they had a reduction of the need for surgery by like a huge percentage.
Yeah.
And of course, the surgeons kicked back, everyone complained and they got rid of the program. So, I mean, it just shows what's going on with this whole system, right?
But we have a lot of our DPC docs that are offering yoga and fitness instruction. And my favorite doc out there is a sports medicine guy. I'm a cyclist and skier. So I do yoga every morning, and I'm 61 years old. I grew this beard because if I'm going to be as old as Santa Claus, I might as well look like him. But, that's how you keep people healthy. And a primary care doctor is always going to be your best friend and recommending those kinds of things before back surgery or bariatric surgery.
Exactly. Thanks. Okay, Sharon, you're next.
Well, hi. Thanks, Jay. Well, listening to this, it's making me remember that phrase about you put the government in charge of the Sahara Desert. It's going to run out of sand. And I'm really, I'm a naturopath, and I'm looking for some kind of freedom government shouldn't even be involved in healthcare and medicine. Actually, medical and healthcare should be totally separate paradigms, because medical doctors, for the most part, really don't understand health. And so I'm looking for some kind of a plan for people that don't do drugs, don't use medical care. It's interesting. I'm in a community here with people that, one guy broke his foot. He never went to the doctor or the hospital or anything. Another guy just had a head injury. We're all treating each other with homeopathics and neural reset therapies, and they won't go near the medical system. And if we could just lower health care, like insurance, where we can get just major medical because I'm paying like $650 a month for a Liberty Health Share, and we never use it because I am our doctor. My husband's 74. We work 12 hours a day. We feel great. So I think there is a need right now for people that don't want to be part of medical care and drug sponsored health care. But
let me rephrase that question a little bit. Thanks, Sharon. We're out of time. Jay, one wonderful dynamic I've noticed with our DPC presentations over the years is the change that has happened with the doctors because of the time they get with the patients. They become more integrated as they look for more creative ways to treat their patients. Have you seen that dynamic with your members?
Oh, sure. And the kinds of things you're talking about, look, they probably believe you. I mean, they're not going to tell you that, doctors don't know anything about healthcare, but, the whole ethic here is to try to do things before you give them the pill, before you give them the surgery, before you give them the advanced treatment. I mean, we've got the diabetes prevention program is like, you send people to the Y and you do diet, exercise, smoking cessation classes. You can reduce the onset of type 2 diabetes in a 60-year-old adult by 66%. Metformin, 33%. So what are the results there? But your doctor, your primary care doctor, is the one that ought to be, the sort of general contractor that's putting together the team that's going to deliver healthcare to you. And if they're not offering those kinds of non-invasive things to you first, I would say go get a new doctor.
Yeah, and that's just to jump in. That's the idea behind the pavilion, or maybe places like that where you can put all of that together with the services, the facilities to do the yoga, to do work on your diet, nutritionists, and so on. Let me. We're running out of time. Let me go to Nina.
Hi there. I want to let Jay know that I'm working for someone who's running for state senate down here in Virginia Beach. So if there's anything way we can be helpful, I've already told him about my DPC, and we're going to have hopefully a meeting sometime at the end of May with my DPC and another DPC who's involved in lobbying in Richmond to educate the candidate about DPC practice. So if there's any way we can connect, I think we might be helpful with each other's efforts.
That's awesome. I'm a Virginian myself, and would love to help. We did pass a DPC law after Governor Terry McAuliffe vetoed it once, and we got what we need there. But with that in hand, we're looking to maybe work with the state employees in Virginia to offer DPC as an option, like we're doing in New Jersey. So let's get together offline and connect about that. I think that's a really exciting thing, and if the legislature's behind it, I think we can easily get this governor to back that.
I would love to be part of the conversation. I've been working on some of the same issues as that. I'm here in Richmond, Virginia.
Perfect.
Okay. I don't know how to get connected to you guys. How do we get connected?
Go to the chat. Go to the chat and put your contact information in the chat. You can share it. Okay.
You'll get me people's info, so I can.
And we'll have it on the. Yeah, we'll get it too. Pam, before you go, I just want to double check. Mark, I guess your question was answered or something, or you're out of the car. Mark Aubrey.
No, go ahead, Pamela. Go ahead and
Okay.
send Pamela.
All right.
I'm just trying to figure out why we need to. The healthcare is a relationship between the individual and the professional. I don't understand why we have to have the government in the middle of it. That's just my.
Yeah. Okay. Hi, Pam.
Hello, how are you? Thanks so much for taking my question. I was actually just curious, Jay, what sort of tools do you guys use as you're talking with patients to figure out either root cause or to figure out contraindications from medications, depletions, et cetera? And are there things that are helpful as far as a practice management?
What's the most time do you have a fee for service doc?
Yes, I have
What's
seen
the
one.
most time you get to spend with your doc?
Oh, I think 16 minutes.
Oh, that's good.
And they charged me twice for those 16 minutes.
Typically, our doctors block their time in hour blocks. They don't always use that full hour, but the secret sauce really is in, as Mark just put it, I think it was Mark, the relationship. The value equation of DPC is you're not paying a fee for a service. You're not even paying a fee for medical care broadly. You are paying for a relationship between a patient and a doctor on a routine.
Okay, so while I appreciate that and I appreciate the fee aspect, I'm curious, you as a doctor, because so often we think Western medicine just goes straight to medications. How do you assess your patients and by the way, we work in AI and using assessment tools. So I'm really curious as to tools for your practice, what is working for you right now, other than just school that you went to and PE credits.
Yeah, in technology, I mean, these docs, again, are unfettered by the bounds of fee for service to use whatever technology they want. If a doctor wants to use AI as a part of his or her decision-making toolkit, they're going to. I personally, I love the whole where tech is going, but I want that learned intermediary, that doctor, to be overseeing that to, really tell me where things are going. So I'm a big believer, maybe just because of my age and experience, that I want somebody that I trust. It's my guide in that. I didn't go to med school. I don't understand these things. And I think that, we really do need somebody that is an advocate on our side as a professional advocate that knows what they're doing. I mean, you wouldn't go into a courtroom without a lawyer. You wouldn't go up on Capitol Hill and try to pass a bill without somebody who knew how to draft the language for you. You don't want to be in diagnosing a complex condition using, some chatbot on your phone without having somebody to look at it. I had a case recently where Apple Watch was telling me I had AFib, and I happened to be with one of my DPC docs, and it also could give a complete EKG. And the doc looked at the EKG and said, "Hey, this is a pretty cool EKG you can get on your iPhone." What it tells me is that you probably went out and drank a lot last night, and you got your AFib because you were drinking a little bit too much. But understanding where your resting heart rate is and what your sinus rhythm looks like, you're probably pretty good. But hey, maybe better go see a cardiologist just in case. That's the kind of relationship you get when you talk to your DPC doctor, not just, oh, here's an appointment to a cardiologist, or, here's the heart medication because you got AFib. Or, it is that relationship that really is the secret sauce that holds all this stuff together.
So basically combining the art and the science of medicine. So the physician being the art, science being the background behind it.
And these are the first people to use the new tech, the new sciences, the new drugs when they're out there. Some, like the Hep C drugs that came through, sure, they were $100,000 a year, but I lost my sister to Hep C 10 years ago. It's like you could save somebody's life. And guess what? It can be administered in primary care, not in an infusion center or a hospital. So these are the kinds of things that docs are able to do when, again, you take the gloves off and let them do primary care.
Okay, Linda, I'm going to come to your question in a minute, but
No, very short, because you answer my question, which could be, how are you going to deal with digital medicine? That's it.
We're going to do it to the best we can.
Okay.
So we're at the top of the hour. Why don't give us a kind of closing summary, Jay, and how people can reach you. Obviously, there's a need here and a demand. So take it away.
Yeah, thank you for having me. We really want to partner with anybody that wants to help this great innovative practice model grow. That's what we're all about. We're very partisan in that way. We're about DPC. So we're really excited that brokers, employers, and other people in the healthcare ecosystem are looking at what we're doing with DPC as a high value service. And we just want to work with you. dpcare.org is our website. Go on, have a look. It's woefully out of date. They can pay me to do lobbying or pay me to manage a website and probably do more lobbying than website managing. But the reality is we'd love to chat. Charles has my contact information. Happy to share the deck with you as well, which is all there. Please reach out, be in touch. My cell phone is on that, and happy to have a conversation anytime with anybody that wants either more information or docs that they can work with from our coalition.